Hi, and welcome everybody. Welcome to EuroNurse. We meet every Saturday at 9 a.m. Central Times. I would say Central Daylight Time, but it's switching, so keep that in mind. You need to move your clocks. If you're watching us on YouTube, great, welcome. We also encourage you to check out our website at euronurse.com to find out more information about the show, watch previous programs. And also, if you want to join in and be able to ask questions, that's where you need to join us through the Zoom meeting. You can sign up to be an attendee. As an attendee, you'll get notifications every week about the upcoming shows. So it's kind of a nice thing as a reminder. But hey, welcome either way. You can check us out either way. We're here. Got a really great show today for you. We're going to be talking about the third part of erectile dysfunction, and I'll be talking about that. So I'm hopefully that'll kind of finish up our series unless somebody comes up with another option or thought towards what we can talk about. I know there's a few other things that I haven't mentioned that we might be able to get a speaker for, such as those extracorporeal shock treatments for erectile dysfunction that I don't really know much about. Anyway, we're gonna have a really good show for you today. I'm gonna switch over my slideshow here. And hey, congratulations to all the urology nurses and associates. This is your week to be congratulated for what you do. And it is an important job. We know that. I went through and got a few congratulations from around the internet. So this was the one that came off of the SUNA site. Also, 180 Medical had several of these things. I know they've been coming around and giving out some stuff they usually come around and give stuff out to the nurses to celebrate Nurses Week. And our partners over at the AUA also wishing everybody a happy Urology Nurses and Associates Week. And finally, I found this interesting tab with a urology nurse. You're in good hands. Little play on words. I talked about YouTube just to let you know, YouTube is a big factor in our shows. We've had 964 views of our past shows. So we're getting a lot of people that are watching us after the show. So that's always great. Video on demand. We're up to 41 subscribers, and you can help. You can go to our YouTube channel and there's a like button. We know there won't be anybody hitting the dislike button. There's also the subscribe button. And if we get enough subscribers, eventually I'll make a fortune on it. No, just kidding. But there is a higher ratings and things that you get from YouTube if you have more subscribers and more views. So I kind of thought this was going to be something that was just not going to be a lot of people showing up for, but I've been surprised. And there's been a lot of patients or attendees for this conference, this weekly webinar. So let me just switch this over here. So as we've done in the past, I'm going to go into the favorite stories. If anybody, as an attendee, you can go and submit those on the Q&A. Again, if you have any questions, general questions before the webinar starts on the erectile dysfunction, feel free to put those in the Q&A box. If you have questions as I'm going through the webinar and you think of something you want to make sure you don't forget, go ahead, put it in the Q&A box. We'll answer those questions after we finish the talk. So favorite stories. I'm going to have one for you today. Another vasectomy story. This one is I think kind of neat. So patient comes into the office, typical guy. And, my job is to get him prepped for the procedure, checking, make sure he's not on blood thinners and all that good stuff. So anyway, I tell the patient, okay, so we'll get you ready. And he goes, hey, listen, man, I'm really nervous about this. I go, well, most guys are, not to worry. He says, but I'm telling you, anything that comes up, he says, I'm out of here. I'm like, well, that's kind of crazy. If you don't want to have it done, this is voluntary. You don't have to have it done. He says, oh, no. He says, my wife and I have talked about it. She says, I got to get this done. I said, fine. If you're really sure you want it, you signed your consent, you want to get it done, let's get it done. He goes, but if anything happens, he says, an act of God, he says, I'm out of here. I go, really? You really want to have this done? And he goes, no, I got to get it done. I said, so fine. So anyway, and it's a crazy story, right? Got the guy down on the table. I'm getting ready to prep him. I'm gonna, get the razor out to shave. And in the rooms that we have our suite set up for surgery, there's no windows. So you rely strictly on the lights and the surgical light and all that stuff. All of a sudden, boom, it goes black. I'm like, holy cow. I mean, it was dark. And we have some emergency generators, but they didn't kick anything on in there except for the sockets. So the lights were completely gone. And he goes, that's it. I know it's an act of God. He says, I'm out of here. And he did. He got up and left. I don't know if he ever did come back and reschedule it, but that was it. It was his act of God telling him that he shouldn't get his vasectomy. Now, the reason this happened, just for those that might wonder, is some car had hit a pole outside, the electrical pole outside of our office, and knocked it over and took out all the power to the entire building. Now, the way we do our vasectomies is I'm in one suite setting the patient up who's next, and the doc who's doing the surgeries in the other suite. So we have two suites going. So he had the same issue. The lights all went out. And so he's over trying to finish up his vasectomy, and there's no lights. So I went and I got some pen lights, those, to check eyes, pupils. And I'm using two of these pen lights to hold over the patient's scrotum, because we had one electric socket that would work for the hyfricator. And he finished up the surgery with pen lights. He was pretty close to done, thankfully. Craziest day. So you never know what's going to happen. So if you have any interesting stories like that, I'm sure somebody can beat my story. Feel free to let us know. So Andrea, why don't you introduce yourself in case we have anybody new?
Hi, my name's Andrea Strong. I am a nurse practitioner in urology. I just celebrated my 1-year anniversary as a nurse practitioner. I've been working in urology as a nurse since 2010. I am certified as a urology registered nurse, and I'm wearing my pin today to sort of support and advocate for anyone who's interested in certification. I think it's really important. And honestly, studying for that exam wasn't too bad. I just did, I think, 1 hour, 5 days a week for 3 months. And it really helped me be more confident in my practice as a registered nurse. And it just made being a nurse a lot more fun when you're feeling confident and good about the care that you're providing. So if you're interested, I really encourage you to go for certification.
Yeah, I agree. And actually, Kathy Marchese, one of our Chicago Metro members, is been the past president of the certification board. And she's agreed. I just have to pick a date out with her that she'll come and talk a little bit more about how to prepare for certification, what you need to do. I have an interesting story about certification. So I early on decided to become certified. And back in the early years of certification, you had to recertify, I think, every 3 years. And you had the choice was you could do some kind of module. And that to me sounded like a lot of work, or take the test again. So I've actually been certified twice by taking the test. So wow. I took the test the second time, passed the second time, passed the first time, obviously. So it can be passed. It's not that hard. I mean, if you're working in urology, you've got the experience and you do the studying, you have to kind of brush up on everything, because it covers a little bit of all of our aspects of urology. But I fortunately now you won't have to take the test twice or do a module. It's just a matter of keeping up on your contact hours. And we're looking at even offering some contact hours attached to our webinar. So we're going to see how that works. But, just get your contact hours in urology. I think it's 20 hours you need now every 2 or 3 years, whatever it is. I forget. But it's easy to stay certified. So once you're certified, it's easy to maintain it. So, or take the test again if you want to do like me.
I think you're the only person who tested again to get certified.
I would do anything not to have to do a written project. It was just crazy. But hey, that was me. Any questions in the audience? Feel free to fill out that Q&A, because if you don't, we're more than glad to start the second half of our show with our talk. I'm anxious to get going at it anyway. So if we don't see any questions coming in, I don't see anybody up with a question. So I'm going to take that as a let's get the show rolling talk. All righty. So I'm going to switch over here. Okay. So welcome. So we've now getting to the third part of our erectile dysfunction. As I'd mentioned earlier, I think one of the really nice things that this type of format offers is the ability to take a deep dive. Normally you talk about erectile dysfunction, you would do this in a 1 hour lecture and try to touch on a little bit of everything. And I think that we've really done a great job of trying to dig in deep and talk about the issues and the treatments and some of the things that go along with erectile dysfunction. So today we're going to just look at the pharmacologic erections. You can always go back to our website and view the previous part 1 and 2. They're available. I will tell you, in order to watch part 1 and 2 on YouTube, because we run these off of YouTube, you have to be a YouTube member, because it has a over 18 requirement they slap on it. So anything that has any pictures that might be questionable, and it's hard to do a talk on erectile dysfunction without a penis picture. So they'll take down my site if I don't make an 18 or over restriction. But in order to watch them, you have to have an account so that it can prove that you're saying, yes, I'm over 18 years old. That's probably a good thing. We don't need kids looking at these things for the wrong reasons. So anyway, let's get rolling. So we're going to talk about pharmacologic erections. When we're thinking of pharmacological erections, it's the same chemical, 2 different ways to get this chemical in. One is injections, the other is urethral suppositories. So I'm going to start off with a talk just about the injectables. And I think that it's always nice to take that deep dive into the history of pharmacologic erections. So how did this whole thing get started? And it's kind of an interesting guy. There's a doctor by the name of Giles Brindley. If you haven't heard of him, or maybe you did, he's kind of somewhat famous. He was he's not an MD, but he was I think a physiologist who was doing a lot of work in chemicals and mostly in things that had to do with the eye and color issues and stuff like that. But he got really involved in the problems with erections, so involved that he used himself as a patient and injected his penis with over 30 different drugs until he found just the right drug. That drug that he settled on was papaverine. Now, Dr. Brindley was pretty proud of his results. And actually, in 1983, he presented at the AUA in Vegas. And what he did is he injected himself prior to coming on stage, gave his talk. At the end of this talk, he dropped his drawers to show off the results. Now, of course, it made quite a splash to the talk and made him well remembered. Although I think he took it a little too far, because he decided to give some of the audience the opportunity to confirm the degree of tumescence. With his pants at his knees, he waddled down the stairs, approaching the urologist and their partners in the front row. As he approached them, the erection waggling before him, 4 or 5 of the women didn't take it too well and threw their arms up in the air and screamed loudly. So I think you can make a little bit too much of a point. But anyway, that's what he's famous for. And that's kind of kicked off this whole erection by injection. A doctor who is a urologist, Adrian Zorgnati, began teaching patients, and he kind of perfected it a little bit with the papaverine, because you had to use a fairly high dose, and there's the higher doses, the higher the side effects. So he added phentolamine to the injections, to the papaverine, and began teaching patients about self-injection. And one of the urologists I worked with was really involved in sexual health, and he knew Zorgnati, and he also knew another guy by the name of Erwin Goldstein. And he actually told me, call this guy's PA. He's doing all the teaching. He says, I think you should get involved in this. So that's how I began teaching patients about self-injections. So pretty early on, all we had was phentolamine and papaverine to inject patients with. And the mixtures that I was using was 30 to 60 milligrams. And the phentolamine, which is Regentine by trade name, is 1 milligram. So that was always the same, and the 30 to 60 could be adjusted. And what you would mix is so that you would have a 1 cc would equal probably 30 milligrams with 1 milligram of phentolamine. And then patients could titrate that, or I could, figure out up or down if it worked too well or not well enough. So I began teaching patients about self-injection. Now, you might think that, when you got a needle and you're coming at a patient's penis, that you probably wouldn't have too many candidates for this treatment. Well, was I wrong? Because patients were coming in like crazy wanting to learn how to do self-injections. And the demand for me was getting nuts. So the docs started a clinic just for me on Fridays. I would do the erection clinic where I'd have patients come in and I would be doing all this teaching. And back then I had to custom mix the medications. You couldn't get it from the pharmacy, but you could get the medications ourselves. And we'd make our own custom formulas for them. This was a little even before compounding pharmacies were around. So it was a pretty big demand. And I started wondering, where are all these patients coming from? Because patients were coming in and they were calling and trying to make an appointment with just me. They said, I don't want to see the doctor. I just need to see that nurse who's able to give me that shot. And of course, we never did that. The docs always saw the patients first and went through all the testing and requisites to make sure they were a good candidate. We worked as a team, but it was crazy. Then I found out how I was getting all these referrals. Well, I do have business cards and patients were picking up those business cards. And they would take those business cards to their favorite bar and give them out to their friends. And our office happened to be right across the street from a bar called Petey's. And I found out the bartender had a whole stack of my cards that he was handing them out anytime one of his patrons would complain about, hey, things weren't working. They go, oh, go see this Vic guy. He'll fix you right up. So actually got quite a reputation in the erectile dysfunction arena for this. So papaverine and phentolamine were the two drugs that were mixed together, and this is what we were using. And they were great drugs. I mean, this really worked. It caused or helped patients to deal with erection problems. And this was before any of these other drugs like orals were around. Only one small problem, well, maybe two small problems: pain and priapism. So this is one of the side effects of the shot, and probably the more serious one is priapism. But pain is reported in about 15 to 35% of patients. And it's typically, penile pain, although it can be groin pain, testicle pain. Most patients, it's not terrible pain and they can deal with it. And sometimes it'll subside as they start using the medication. But there's a small subgroup, maybe 10% or less, that the pain is so terrible that they won't use the drug. I mean, it's just, they can't have sex. It hurts too much to like even touch their penis. It subsides after the medication wears off. So don't fear, but it is out there. I did a little research. Again, we're doing the deep dive for you folks. One of the ways that they talked about, there was a study that was done in 1996 and published in Urology, that you could slow inject the medication. And I think that's a real issue, because patients, when they're doing these self-injections, they usually want to just get it over with. So some of them will push the medications pretty fast. So if they're complaining of pain, one of the things that you can recommend is slow it down, take your time. Now, other things that can be done to help improve the discomfort or pain is changing what medications you use, what mixtures we use. We'll talk about some of the other options that are out there besides the papaverine, phentolamine, and prostaglandin E1, as we're talking about in this particular slide. But the pain can be dealt with and can be managed. There's also an article I was reading too. This was more recent, 1998. And they were looking at the alleviation of the penile pain by adding something called neurotropin to the injection, and found it to be very safe and did decrease penile pain. Now, I will tell you, I've never used that. I've never had that issue bad enough for patients. But, I think in retrospect, I know there's been a handful of patients in my career that tried the shot and would never try it again because it hurt so much. So they may have been a candidate for this. So I think it's always good to take that deep dive and look in the literature and see what else is out there to try to help improve the results for patients, so they have more options. That's always the best part. Now, as far as priapism goes, prolonged erection can occur in about 18% of patients. This was tested with papaverine and phentolamine. However, I can tell you that prostaglandin E1 has similar results. There is a risk for patients that are going to, find out that they're going to get an erection that won't go away. So you do have to have some kind of plan in place. If you're going to do this type of work, make sure that your plan for what to do if somebody has a priapism is there. Now, one of the things that I found a lot of success with is Sudafed. And I always give the patients instructions that if their erection lasts over 4 hours, that they should have Sudafed on hand, a 60 milligram over-the-counter tablet. It's an antihistamine. typically will get rid of the erection. It's worked most of the time, not all the time. There's been some talk in the literature about trying cold water and compressing the penis to try to help to get it to go away, but the Sudafed works the best. There's another drug called terbutaline that you can take. That's a prescription item. I never used it. Usually, like I said, most of the time the success with Sudafed was pretty good, but it's never 100%. So patients have to also be told what to do if it doesn't go away. Now, priapism is not something you can, just sit around and not worry about, because if the penis stays erect long enough, it can start to form some blood clots in there and can cause some ischemia, and could, permanently damage the penis, preventing erections in the future. So you have to have that plan in place, and patients have to be aware of it. I'll never forget a patient who called me, and he was one of my patients that was using the drug, and he was getting ready to get on a plane for a international flight, and he injected himself at like 2 a.m. in the morning. And now I just got to the office and it's like 6 o'clock. So he's had this erection now for 4 hours. It won't go away. And he's calling, and I get the call, and he goes, "Can I get on the plane?" I go, "Absolutely not." He says, "But it's an international flight." He says, "I can't, I'm going to lose my money on it." I says, "You may lose more than your money." I says, "It's bad planning." So, this guy obviously had to go in an emergency room and get treated. But that's just kind of, some of the things you need to make sure patients are aware of. Probably not a great idea to give yourself a shot right before you're going to get on an international flight. Now, if it doesn't work, the Sudafed doesn't work, and it's not 100% for sure, then they need to go to be treated. And generally you can have coordinate with the emergency services, emergency room docs, and give them your formula. So a lot of times they can handle, because the one thing that, our docs weren't always that crazy about was being the doc on call when somebody ended up, injecting themselves, and now it's 4 a.m. and they need to have it reduced. But the treatment is generally pretty easily given. It's successful, and they dilute neosynephrine, that's phenylephrine, in 9 cc's. So 1 amp or 10 milligrams of that diluted with 9 cc's of normal saline to produce a 1 milligram per cc dose. And we inject, now this is done by the physicians. It's injected 0.3 to 0.5 milligrams intracavernosally every 10 minutes until detumescence occurs. And the max dose of this is then 2 cc's. Now, if this is unsuccessful, that's when you get into the irrigations of the corporal body. So they have to go and put in large 19 gauge butterfly needles. 19 gauge is a pretty big needle into each corporal body. And you can then inject this mixture of neosynephrine into there. And they really basically kind of try to, irrigate out the clots that have formed inside the cavernosal bodies. And that's always been successful. If that's not, then they're, it's surgical. So this formula is something that you should have on board, so that, your physicians should be aware of it. And sometimes, like I said, it's helpful if the emergency room department has it. A lot of times they can go ahead and start by giving the initial shots. Normally they'll call in urology once it involves putting big bore needles into the corporal cavernosa and doing irrigations. Fortunately, I'll tell you, there hasn't been a lot of patients that we've had to go on to that extent. The bulk have been treated well with Sudafed. The other issue with injections is plaque formation. So you can form these plaques sort of like a Peyronie's from the injections. One of the things we always tell patients is you can't inject every day. We recommend no more than, like, I always say 12 times a month, but 2 to 3 injections per week. And they're not really sure what causes this. It could be just the physical, poking through the cavernosal body that could set up a scar. And it obviously doesn't happen to everyone, but it can happen. And severe, it'll cause curvature. I will tell you that in my career, I've only seen a few plaques form. I've never seen one cause curvature, but they can form these little plaques. We always recommend patients that are on injections, make sure that they have their urologist examine the penis yearly to make sure there's no plaques. If they're forming plaques, this is probably not a good treatment option, because then again, these could become severe enough that they may need to have intervention done to treat those. Now, fortunately, we have the same drugs that they use for treating the Peyronie's disease can be utilized for these plaques to help dissolve them. But some people just are going to form plaques for unknown reasons, and that's the injections can be one of those causes. Now, this is kind of a funny story. So back early on in my injection career, again, I was mixing patients, the papaverine, phentolamine mixture for patients, and a drug rep from Upjohn stops by the office and says, "Hey, I hear you're doing a lot of this erection treatment stuff." And I go, "Yeah." He says, "I got a drug I think you should be interested in." He says, "We use this drug called L-prostadil to treat patent ductus arteriosus in children." But he says, "I know a lot of doctors now that are treating erectile dysfunction with it." Now, L-prostadil is prostaglandin E1, and it's the backbone of erectile injections. The dose is very low, 10 to 20 micrograms to work. And so he said, "I'll get you samples," which was great. You know, anytime you can get free samples. So talked to our physicians that I worked with and said, "Hey, this new drug just came out. I think it sounds pretty promising. Little cleaner profile than papaverine. Papaverine can have some effect on liver enzymes. So if you're using papaverine, you should be running, you know, normal patients should have a liver enzyme check just to make sure there's no changes. I can't tell you a patient I've seen that has had a change in their liver enzymes, but it's possible. But prostaglandin E1 doesn't have any effect on the liver. So a nice clean drug to use. So that's where I started switching over. So it was, you dilute it down and you want to get anywhere between 10 to 20 micrograms per cc. And then you could titrate because I utilize those, syringes where 1 cc is insulin syringe. So each unit at 10 units is 1/10 of a cc. So it can be a 1 cc insulin syringe that you use to inject, or you can use a 1 cc like tuberculin syringe, which is marked off in 1/10 of a milliliter or units for the diabetic syringe. But those are the ones that I always utilize. So it's nice to titrate that way. But in July of 1995, Pfizer came out with the first FDA approved form of prostaglandin E1, and that was the Caverject Impulse. And the one drawback of prostaglandin is it's temperature sensitive. So if you left it sitting out on the counter, it's going to be garbage. It won't work. Won't hurt them, but it won't work. So you have to keep it refrigerated. So that was always an issue. And that was an issue with the FDA as far as approving it in its native form. So what Pfizer did is they powdered it so that it could be kept at room temperature for storage. And that's what the Caverject Impulse looks like. And it's kind of a neat little syringe system. So what you have is a mixing syringe. You put this little cap on at the time of you're getting ready to utilize it. So it punctures this little cap in here. So everything stays nice and sterile for you. And then you go to this plunger rod and you start twisting it. And as you twist it, it starts to push the water that's inside here into the powder. The powder will mix instantly as soon as it gets wet. And you've got your dose mixed. And then it has this dose window so you can actually twist it. So the 10 microgram will give you 4 different dosing options. So you get 2.5, 5, 7.5, and 10. And then the 20 will give you up to 20. Again, the same type of breakdown. I think I've got some figures on how you do this. So as you can see from the figures, is you wipe off the tip with some alcohol, take off this little protective covering, screw that on, then you twist that. And then this is what the dose looks like. So you can see the number in there. So you always want to find the lowest dose that works. I can tell you that every patient wants to try the highest dose there is because they think they're going to get a better erection. It doesn't work that way. More medicine does not cause a harder erection. Once you achieve an erection, that dose is going to give you as hard as erection as you'll get. More medicine will make a longer erection. It's the high enough dose, you're going to put your risk for priapism up. So always try to use the lowest dose and stress that to patients. But I can tell you, guys are funny. They give me the biggest, baddest dose you have. In 1997, a company by the name of Schwartz came along with a dose of Caverject with their own type of dispensing system called Edex. Edex was my favorite drug to use. And the reason I liked Edex the best was because it came in 10, 20, and 40 microgram. I can tell you that I've had patients fail at 20 and succeed at 40 micrograms. So having a little larger dose goes a long way. Very similar type of setup here, where you have this, this part here is reusable. You just open this up and then this little cartridge goes in, and this cartridge has a little bump in here. So it only goes one way, and you just slide that in, as you see here. And then you screw that little plunger mechanism onto the back, and then you push it forward, and it does the same thing. As you push the water up into the syringe here, you start to push this up, it has the water column between these two little stoppers, and it reaches a point where it goes up and over that, and then gets the powdered prostaglandin wet and causes it to reconstitute. I say prostaglandin E1 reminds you of powdered sugar. It reconstitutes that easily. And as you can see, then you can, again, as you see from this blow up here, you can control your dose by the amount of medication you give. Now, you're always wasting with all these drugs. If you're giving less than a 1 cc dose, you're going to just waste it. You can't save it for other uses. That was kind of the things patients liked about the ampule of medicine that they kept in their fridge. They could just draw out their dose. So if they're using 1/10 of a cc, 1 cc goes a long way. But again, this one, you don't have that option, but you control your dose. This one doesn't have numbers, but it's 1 cc, 0.75, 0.5, and 0.25. Now, I always teach patients to do self-injection the same way. I find the best system to do this is to have the patient grab hold of the head of their penis. If they've got a foreskin, pull the foreskin back so you're grabbing the head of the penis, because the corporal bodies are going to be attached to the head of the penis. So if you're pulling the skin, you may not really stretch out the corporal bodies. You want to stretch it, pull it across the skin, and then inject anywhere in this area. I find that closer to the base, the corporal bodies are bigger and they get narrower as they get towards the head, but as long as you hit them, it's going to be fine. That needle looks a lot longer than it is. A 27 gauge needle. I think it's a 0.5 cc in length that comes on the kit. And this is really another nice example of how this area that you want to be able to show patients to inject in. And that's kind of the technique going in. I always tell patients the easiest way to do this is bring the needle right up to your skin. Just kind of touch the skin and then give it a good hard push to bury it. The cavernosal bodies are pretty hard. They're pretty tough. And as you try to push through that, I've had patients inject under the skin, and all they do is get a nice little blurb bleb underneath the skin, but they don't get the reaction. It doesn't work. So I always tell patients, make sure that you bury it. And I find it's really helpful if you've got a model in your office or a diagram like this that you can show patients and show them what they're going through, that they're going through the skin, this tough buck's fascia, until you get into this corporal body. And you want to make sure that you bury the needle, because if you don't, you can inject in this space. I think if you make that clear to patients, they'll do a pretty good job. Now, the other thing I warn patients about all the time is to make sure that they're not injecting on the top, not injecting on the bottom. So the top is a nerve, and if patients inject the nerve, it'll hurt. So patients will complain of pain just from the injecting the nerve. I can tell you that for most patients, they're surprised when they go and inject the penis on the side like I'm showing. They don't feel the needle. The needle's so small that it's not really something that it can sense. So it's I always say that it's small enough to miss all the nerves. The way the penis is designed, all the nerves are towards the head. So the side of the penis doesn't have a lot of nerve supply. You don't want to be injecting on the lower down here, because that's the urethra. I've had patients do it. They inject in the urethra, common call. Hey, I gave myself a shot. It didn't work. And I saw blood come out the tip of my penis. I go, yeah, you injected too low. Now, is there any danger to that? No, it's just usually kind of, distressing to the patient to see blood come out. But I've never seen any, strictures or anything happen from that occurring. But again, definitely worth warning about. This is a nice chart that was put out by Pfizer on their particular drug on how to titrate it for vasculogenic, psychogenic, and mixed etiology cases. I can tell you that one of the big problems that one of the problems patients face with erection is something called performance anxiety. And we had a doctor in our building who was a psychologist that we would refer in the past to for patients that were having performance anxiety and to do some, psychological treatments for them. Well, that guy started sending patients to me. He said, because I had higher success rates with my injections than he ever got with his psychotherapy. He said, sometimes if a patient's got performance anxiety, long as they've got the shot and they get a few under their belt, all of a sudden they don't have to worry about, hey, if I can't get an erection, I can always go in the fridge, grab a syringe and give myself a shot. That takes that performance anxiety away. And most patients, and after about 6 months, they don't have to use the shot anymore. So it's really been a good treatment for psychogenic issues. But anyway, this is the titration they recommend. So they starting dose of very low at 2.5. If it works, great. There's the dose. If it doesn't, they get a partial erection. Then they go up to 5 micrograms. So another second injection. Now, this titration, I don't recommend anybody to send patients home and titrate at their house. This should be done in the office. So you should have a kit that you can give the medications and titrate. So you're looking to see if you get a full erection. Now, you don't have to have the world's, hardest erection. And you have to keep in mind that this may not be the best situation for getting an erection. I always say I'm a nice looking guy, but I'm not going to cause any great erections in the office. So you have to keep that in mind, but you want to push on the head of the penis. And if it doesn't buckle, that's what you're looking for. And all of this, patients should then titrate at home once you get a baseline of where you think you're going to need to be. But anyway, I don't know that I think that this is the best system for the titration. It's not the one I use. So I'm going to give you what I use. And this is experience. I started 10 micrograms. Almost all patients can tolerate 10 micrograms without ending up in the hospital with priapism. So it's a good starting dose. If the patient, again, has no reaction, I would then go ahead and inject them with another 10 micrograms to get it up to 20. So I'm trying to ballpark it. Now, if the guy gets a pretty good erection at 10, you don't go any higher. And depending on how hard it looks, if it's like a really good erection, younger guys, I might prescribe the 10 micrograms, but tell them to start at a lower dose, 5 micrograms, even the 2.5 micrograms. You're always looking for the lowest dose possible. But again, we're trying to see if we can cause an erection, and some patients need higher dosages. So we're up to 20 micrograms. This is all in the same setting. If I come back and I give it a half hour in between each injection. If at 20 micrograms, there's still no erection, I'll go ahead and give them an additional 20 micrograms to bring them all the way up to 40. Remember, EDEX goes up to 40 micrograms. So your goal is to try to test to see whether they're going to be a candidate for pharmacologic erections. In the old days, I would bring patients back and do these tests, try a 10, try a 20, try a 40. That's 3 trips to the office. Patients are busy. I'm busy. And if they keep giving away my cards at the bar, super busy. So I think the going and having a test method that works is good. Now, you might say, well, why is it not working in patients? Because this stuff is pretty successful. Well, there is some issues of something called venous leak syndrome, and I'll talk a little bit about that in a moment. But that's what I'm trying to prove here is whether they have venous leak syndrome or not. Because if they do, none of these injections are going to work. Now, I am going to put a warning here, and this I do like. So they have this pure neurogenic etiology, patients with spinal cord injury. If you're not prepared to deal with these patients, I would avoid teaching them or dealing with them, because they are the ones that are going to get in trouble with not only with the issues of priapism, but they get the wacky blood pressure changes and heart rate changes from the side effects too. You've got to start with a very low dose. My standard dose is 1 microgram to start. Now they show 1.25. But anyway, I start very low and see what happens. If they have no reaction, then I'll gradually work my way up. Most patients with spinal cord injury, doses of 1 microgram sometimes is all it takes to work. And you have to really be careful, because if you came after somebody with a spinal cord injury with a 10 microgram starting dose, you might find yourself in a lot of trouble. So I will warn you about those patients. It's a special case scenario. I dealt with them in my career. Your physicians in our practice were quite comfortable with it. So was I. But again, that's the warning. You have to make sure that you keep that in mind. If somebody's got some kind of spinal cord injury, don't go hog wild with this. And they have to know the same thing. They've got to be very careful in their dosing. Success rates of it. One of the things with injections is they're a high rate of success. The issues that patients have are, needle phobias. Some patients don't want to stick themselves with a needle. Once you get them through the first testing injection, that tends to go away, but that's always one concern. But success rates are great. I'm going to tell you that I can get success rates probably even closer to 90 to 95% with the use of compounding pharmacies, because you can special mix this stuff and come up with something that'll work for most patients. So it's really a great thing to be able to offer patients as a treatment. So compounding pharmacies are available, and they've got all sorts of mixtures that you can come up with. And the big thing is, right now, if you're going to go into a compounding pharmacy, most of them are using what's called trimix. So it's papaverine, phentolamine, and alprostadil, our prostaglandin E1, mixed together. The three drugs have a symbiotic relationship. They all boost each other, and you can use much lower dosages. So remember, I was saying, my concern was papaverine and liver, but we're down to 18 milligrams versus what normally would be 40 milligrams for most patients. So we're using very low dosages of these medications, and standard dose will work. And when you mix standard dose, the patient may not be injecting a whole cc either. Half cc, whatever works, the smallest amount, titrating it up. Now, this is what I like about compounding pharmacies. They're cheap. One of the big issues, and patients that started out with me before the approval of these drugs, the prostaglandin E1s, Edex and Caverject, they were getting their medications for, dollars a shot, compounded. But now all of a sudden you're paying for the cost of an injection, and those injections were not always covered by insurance, mostly weren't, and they're fairly expensive, especially early on. I'm not sure what the current cost is. I meant to look that up, but they are not inexpensive. So they hated it. So a lot of patients wanted to go to something else with compounding pharmacies, and trimix fit that bill perfectly. The other thing I like about compounding pharmacy are what's called the super mix. So that patient that just requires higher doses, what I would typically say maybe was a failure, might be somebody I can rescue with these high dosages. And you can look at down here, they're mixing 80 milligrams of 80 micrograms of phentolamine with 25 milligrams of papaverine, 3 milligrams of regentine. So they're using these super high mixtures, and I have had some patients that are using the high mixtures and getting erections just fine with those. So if that's required, it does give us an option. I always say that you have to have options for patients. Now, if you're going to do this, I highly recommend that you've got handouts to give patients. This is a compounding pharmacy that we use called Anazao Health. They are out of Vegas. They're always look into the compounding pharmacies you're using, because you don't want to pick somebody who's not, properly following the regulations that you should have. Always have the patients waiting 3 days between injections, telling them not to inject more than 12 times a month, keep the mixture refrigerated. And then I think this is the important part here, is what dose the medication I want them to use and the titration. And I tell patients, wait 3 days before increasing your dose, and you're increasing it by 0.1 cc's or 10 units until satisfactory dose is reached, and a max of 100 units. That's 1 cc. Don't be discouraged by poor results, because sometimes the first result's not your best result. And then again, down here, this big warning: if you have an erection over 4 hours, Sudafed, apply an ice pack, wait an hour, still erect, you're calling us, you're going to the emergency room. And I talked about venous leak syndrome. If you visit episode 8, you'll learn more about how erections occur because that was covered in our first episode. But venous leakage has to do with the fact that these drugs work by causing the arteries to expand. And as the corporal bodies grow in space, they start to compress the veins. And that compression causes the blood to stay within the penis, and that causes an erection. But if that blood's leaking out, I always tell patients it's like trying to blow up a balloon with a hole in it. It'll blow up, and that's what you'll see. The penis will start to get hard. It almost looks good, but it goes down right away as soon as they press on it. So it's not going to work. So let's talk about urethral suppositories. I'm going to kind of go through those quickly because not my favorite drug, but in 1996, an option to injecting it, you can give L-prostadil, prostaglandin E1, in the form of a urethral pellet. And it comes in 4 different doses, 125 up to 1,000. I can tell you that most patients require the 500 at minimum to work and up to 1,000. Now, remember, 20 micrograms injection will work. We're giving 1,000 micrograms of this medication. What's that going to spell? Probably more side effects. Comes in a easy to use dispenser, this little button thing that has the pellet. The pellet's right up here in the tip, and you put that deep into the urethra. I've got a picture of how that looks. You just kind of slide this into the penis, a little lube on it to get it in there. And then you go ahead and you push this little button on the top, as you see that finger up here showing. You're pushing that button in, and that'll release the pellet. Once the pellet's released, you want to make sure it stays within the penis. They recommend massaging it to help it dissolve because it does have to dissolve. And then the prostaglandin is absorbed through the urethral walls. Absolute contraindications are priapism, sickle cell, multiple myeloma, and leukemia, anything that can cause cells to stick, Peyronie's, and a penile implant. Obviously, you stick a needle through a penile implant, it's going to leak. But even using the things like the pellets, although it wouldn't puncture it, it's not going to work. Once you have a penile implant, as we talked about in the second part, it's not going to work. So side effects with all these drugs to be careful of. Most of them can lower blood pressure, especially from going from sitting to standing, the orthostatic hypotension. Again, I talked about the pain issue that can occur. Also can be increase in heart rate and fainting, so that standing up too quickly after your blood pressure drops can cause patients to faint. Now, it didn't occur too often with the injections, but with those high doses that we use with the urethral pellets, the mousse, it does. Patients should be warned alcohol and cannabis products should not be used at the same time because they can potentiate the effects. Be careful when operating a car or heavy machinery until you know how well it's going to work, is any effects that it might have, just like you'd warn any other patient. And the PI will tell you that you need to start at a low dose and work your way up. So really, the way you're going to do this is to titrate it. It should be done in the office. So you have a patient that'll probably come to the office 3 or 4 times to properly titrate this. And when you had samples, it was great because you could try it that way. But I don't recommend sending patients home to try this themselves because I've done enough of it. And patients should be brought to the office and titrated in the office so that you can monitor their blood pressure and make sure that it's not going to bottom out on them and they'll pass out. Worse than that is I've seen this big distended veins in the legs from it, and it hurts. Patients are nervous because of the pain from it. It all goes away over time, but it's something I never saw with the injections. I kind of mentioned I'm not a big fan of the mousse pellets. There's why. Also, women have to be partners have to be aware that it can be when they ejaculate, the medicine can get into their vagina. It may cause some irritative effects. If it does, obviously a condom can prevent that. If you're pregnant, it's absolutely not recommended to utilize without a condom. And at this point, I do see we have some questions. So hopefully I've covered a lot of things, but I'm going to go ahead and take the questions so I don't have to do all the talking. Andrea, would you be willing to read the questions off?
Sure. Thanks for that presentation. That was very informative and very entertaining.
Good.
All right. So first question is that there's laws that restrict and limit the sale of pseudoephedrine or Sudafed by pharmacies, as people tend to use it illegally to manufacture methamphetamine. Is there an alternative that patients could buy over the counter?
Not over the counter. So I think all the antihistamines will work. Sudafed just is the best. So you can try something like Benadryl, and but again, the best drug is Sudafed. I think that, if required, if that's an issue, I haven't had the issue. I've had patients be able to buy it in the past, but I do know that about the loss situation. So I do agree that can be a problem, because you want to be able to get the patients the best med. The other one I've seen is, so I think if they're having issues, is I would have the doc prescribe terbutaline. It's that one for breathing. That does work too. So that one I've read studies that it work, and the pseudoephedrine works. So.
Okay. We have a comment from Katie Bortel. Good information.
Oh, thanks, Katie.
Next question is, and I'm not quite sure what this is in reference to. Oh, here we go. Okay. I'm not sure what this is in reference to, but the question is, why can you not take out the medication that is not needed? You can place in fridge and bring to room temp prior to use.
Okay. So I think what they're referring to is like the Caverject, when you don't use it, say your dose, you have a 10 microgram, which is the smallest they make, and you're only able to use 5, you've got half that you're wasting. So the FDA approval, so we're talking FDA approved, is to waste it. Now, could you inject it and save it, or can patients do it? Would it, I guess the question could be answered 2 ways. Would it still be good? Refrigerated? Yes. Now, issues of sterility, that's another concern. We're trusting patients to keep it sterile and that it's going to be, properly preserved and all that. I'm not sure about, but based on what I would recommend the patient do is to waste it, because that's the FDA approved way to do it.
And then just a comment, neurogenic patients need the most help.
Yeah.
Another question here. Usually the compounding pharmacy is cheaper than the copayment or edicts, etc.
Absolutely. And I can tell you that most of the patients that I've dealt with, when compounding pharmacies came out, they all wanted to switch. Very few, unless their insurance was paying. And I've had some patients that had really good insurance and they were getting 100%. And I always tell patients, it's up to you. Look it up. It's, if you want to be willing to, try this, and we could even, if they're satisfactory results with just straight prostaglandin, you don't have to use Trimix. You can prescribe, they'll compound just straight prostaglandin E1 for them. But they're paying far less. We're talking, copays and things that could bring it up to $10 to $40 a shot, and $2 or $3 for the compounded.
Next question. Do RNs or NPs do this teaching?
Yeah, I'm an RN, not an NP. And, you have to have a collaboration agreement with the physicians you're working with. So certainly, it's within the nurse's protocol to teach diabetic injections. So it's certainly within the nurse's realm, that's a urology specialist, to teach penile injections. Now, I'm not saying that you should go out and just take this on yourself. You need to be properly trained. So I worked closely with the physician on how to give penile injections. But once you're equipped with how to give the penile injections, the physician you're working with is, of course, prescribing it, but they rely on the nurse. That's the collaboration side to do the teaching. And that's what we do best. We've got the time, and we take the patients to do that and assess and evaluate and teach patients how to titrate. So definitely within the realm of an RN, and that's always been an RN clinic for our practice. And I think that I've never had any questions that wasn't a safe practice. I think an NP certainly can do it, because you have prescriptive abilities, from start to finish, without necessarily having a collaboration. But again, and you could probably answer this one: would a NP be able to go in and irrigate out corporal bodies?
That's a good question. I have not seen that in my setting, but it's possible that in other settings they have advanced practice providers who are taking care of priapisms.
Yeah.
Yeah. So not
But that's
sure.
always the question. Yeah. So
Yeah.
I think, and I think most nurse practitioners are in collaborative practices too. So you have that ability to, rely on the physicians.
Yep.
The physicians have their strong points and the nursing has their strong points. And I think teaching is one of our best. It's just like self-cath. I don't know a physician in my practice that can teach self-cath as well as my nurses.
Yep. All right. Next comment here. How about a card for the patient's wallet with a receipt to bring down erections for ER use?
Not a bad idea. Yeah. I've never done it, but I can't say that's not, nowadays, I think probably they can put it on their cell phone,
True.
the instructions for it. But since they're not a patient instruction, but I like it, Paula. It's a good idea.
Next comment here is from Paula. They trust the patients to maintain sterilization with compounded. So why would we worry if the patient extracted from edex? The patients could, excuse me, had a frog in my throat. So why would we worry if the patient extracted from edex? The patients could draw out with syringe.
Yeah. Again, so if to go by what's the manufacturer's what's in the PI, and it doesn't talk about taking it out and extracting it and storing it. So you'd have to have a vial to store it in. It doesn't come with something secondary. So when you waste it, you're literally wasting it in the air. There is nothing to put it in. So obviously a patient could purchase an empty vial of something to put it in. But again, I don't like to take the responsibility of teaching somebody something that is not the recommendation, that's not in the PI. And I think that we're at a little different when you're using a compounded pharmacy product and using a product that's FDA approved, and the FDA has kind of written all the requirements of how you need to do this. So for my own safety, I would say that I would not tell the patient to try to save that little extra. They just need to waste it. Again, most of my patients are using compounded pharmacies, so it's not even an issue. They just drop what they need.
It looks like in California, a nurse practitioner can irrigate for prolonged erections. I suspect that would be the case for any state as long as you are trained in how to do that as an advanced practice provider.
Yeah. And certainly the original dose of the pseudoephedrine into the corporal bodies would make a lot of sense. That nurse practitioners should be able to do that.
Next comment here. If you take off the needle on edex, then there's a rubber stopper.
Paula, you're insisting on using that last drop. Again, what people do out there, on their own, I don't really, care. But I won't teach a patient to violate what the FDA has said you should do on their instructions. I just don't think that that's a smart practice myself. And again, if it's a cost issue, which is I'm guessing what it is, far cheaper just to use a compounded pharmacy. And I've had patients that are really happy with it. We have an interesting situation in our area. So compounded pharmacy that I typically would use is this one out of Vegas. They mail it right to the house. It really works out nice that way. But I have a group of patients who live in neighborhoods where the porch pirates were taking their drugs. And so it wasn't good for them, because they would tell me, hey, if it gets sent to my house and I'm not home, I'm not going to get it. So what can you do? So I did look at the options, and I found a pharmacy in their neighborhood, and the real nice pharmacist that started doing his own compounding. And he said that, he says, just send them to my pharmacy. He says, I'll compound it right there for him and give it to them directly, so that they don't have to worry about it being put on their porch. So that's been a great success for that small population. Most of us don't have that issue, but this group I live in I treat patients in the Chicagoland area. So big surprise, a little bit of theft, huh? So anyway, but I think it's all over the country. If you got a bad neighborhood where you can't trust your packages, that's a good idea.
Yep.
And we're getting to the end of our discussion here. I think we have one more from Paula.
Yep. This is a comment. It says, well, it's not covered by insurance. As a nurse practitioner, we can take responsibility. And she just wants to make sure that we all have the information.
Oh, I think it's a great point, Paula. I think, again, we're here to debate things too. Everybody's got different practices and different comfort levels and different things they've done. And I'm not here to say that what I do is the only way or the best way or the perfect way. I'm telling you what's my way. So that's the way I kind of like to approach it. It's been a great time, a great discussion here. Really enjoyed everybody's questions. It was great to have a number of questions come in. I think this is a great subject. If you want to continue the talk, remember, go to euronurse.com and hit that after party button. I'll be more than glad to answer more questions. I'll be over on that side, and we can debate Paul, if you want to go on, we can debate the issue and get even further together. But anyway, so we'll see everybody next week. Don't forget to check our next subject out. You'll get something in the email telling you what's coming up next week. And hey, it's been a pleasure. Thanks for all your help, Andrea. And we'll see all of you who want to come over to the after party coming up next.